Good afternoon. It's great to be here. So, continuing the line of thoughts from the previous speakers, we're trying to develop a GSK proof of principle for the importance of the immune activation for the control and resolution of chronic hepatitis B infection. Starting with a basic assumption that chronic HBV is an immune disease. And most of the adults that are getting infected with hepatitis B are able to resolve the infection through the immune mechanisms. And following the different parts of the immune system that are implicated as important for the resolving that infection, we have tried to build a very comprehensive immune activation strategy as a proof of principle to really establish. Can we do it? How can we do it? And what is the right functionality of the responses that are involved into that? Clearly here into this cartoon, again, you see the importance of the CD8 that everyone agrees. The importance of the CD4 T cells, there is a lot of evidences recently also from the lab of the Georg Lauer. There is a very important evidence that we'll show in the next slide. But not only, there is also the impairment of the B cells and also involvement of the innate responses for the control of the infection, particularly through suppressing some of the interferon gamma production, producing cells like NK cells, for example. I mentioned about this very interesting data from Georg's lab. I think you are all familiar with that, but again, just to point out that when he studied by ICS, that's the same assay that actually we are using at GSK as well to study the T cell responses. In his lab, they're seeing as a very critical differentiator between chronic HBV patients and chronic HBV resolvers. They're seeing the key differentiator of being CD4 T cells. And clearly patients that recover from chronic hepatitis B infection are mounting quite significantly higher responses compared to those that remain under chronicity. Now, everyone is as good as its platforms that is using. So what we have access at GSK is, of course, viral vectors, which we contemplated as inducers of the very potent CD8 responses. But what we thought that we should do in the best possible way, affordable for us, is to induce very strong CD4 responses and also antibody responses. Again, the importance of the antibodies are several-fold, but one very important one is to prevent, if you build a strong anti-HBs responses, for example, you might be able to prevent the sorry for that, the infection of the clean hepatocytes. And so we have run this clinical study. It's a clinical research study in which we actually use a recombinant HBs antigen, and we adjuvanted it with several different adjuvants that are available in the GSK portfolio. Not all of them, but we have picked up several. The first one is AS01, which you're all familiar from Shingrix, Mosquirix, etc. Is MPL QS21 type of adjuvant. And the second one is the difference between B and E versions is actually the amount of active ingredient that go into that formulation. ASO3 is another adjuvant which is all in water based, and ASO4 is alum plus MPL. So the study basically involved 2 doses a month apart, healthy volunteers, and we've been looking into a number of different outcomes. Antibody generation, memory B cells, and CD4 T cells. And of course, that has been done by ICS as well. So as you can see in these graphs here, in terms of memory B cells and antibodies, ASO1B and ASO3 perform about the same. But when it comes to CD4s, ASO1 is a clear winner. So we have selected ASO1 adjuvantation as a way forward. In addition to that, that's a result from the same study published in different paper on the bottom right. We are seeing very strong innate activation signature as a result of the use of AS01. You see on this panel several different cytokines that has been very clearly induced as a result of the prime and the boost. IL-6, IP-10, MIP-1 beta clearly involved with antibody production, but also others like interferon gamma, IL-10, MIP-1 beta, and MCP2 involved in antiviral pathways. Now, based on that, we have devised immunotherapy strategy that consists of the viral vectors, and again, that is viral vectors in this case, chimp adenoviral vector and MVA, and we are using genetic adjuvant, referred as a HLI, and the purpose of that is to really limit induction to the CD8s, but to maximize that CD8 T-cell induction. And we are counting on the recombinant protein on the bottom, HB Core and HBS, adjuvanted with AS01 to induce that potent CD4 T-cells and to induce the innate responses. So this is how it looks like, the overall milieu of the components that we're using. And as you can see now, there are basically 4 components of that immunotherapy. And we are running currently 2 different phase 2 studies. One we refer as monotherapy VV01 on the left side. So that explores 2 different regimens. One is a sequential regimen that consists of 2 months apart adeno, MVA, and 2 recombinant protein doses after that, at the days that are indicated there. But then there is another one, we refer to that as a step C, and that uses actually concomitant administration of, during the day 1, we are giving adeno and recombinant proteins, and then every 2 months after, we're giving to the patients MVA plus recombinant proteins. And so the patient pool here is HBe negative patients under control of NUCs, and they're all comers. They're not predefined by baseline HBS level. On the other phase 2 study, that is a combination study. We explore different hypotheses. That's a combination study between bepirovirsen and immunotherapy, and both of these studies will generate efficacy data next year and will be reported at the time. On the next slide, I will show you some interim data that was presented during the last ASLD, and particularly to focus on the right side, where we see the CD4 T cells. So the group B2, I don't know if I can use the pointer somehow, but the very top right, the group B2 is the group that actually has received only recombinant proteins. And so what you see here with the arrows, you see the results after the 2 doses of the recombinant proteins. And the level of CD4s that we're able to induce. So, for example, in that particular case, after the day 15, which is very significant increase compared to the baseline, with a mean of around 2,000, a little bit more than 2,000 CD4 T cells per million, is in fact quite close to the range that Georg Lauer is seeing in these patients that resolve chronic hepatitis B, and that level is clearly maintained during the next follow-ups. So this is my summary. So as I said in the beginning, we're really looking into the strategy that is quite comprehensive, try to establish proof of principle on the importance of different components activation of the immune system. Of course, jury is still out to see what is the relevant contribution of each one of that, and perhaps the most importantly, what is the right functionality of the T-cell response that is associated with functional outcome. Thank you.